Non-odontogenic bone tumors are tumors that are not composed of cellular constituents whose primary purpose is to form teeth or teeth-related structures. There are two types of non-odontogenic bone tumors: benign, malignant. Starting with the benign non-odontogenic tumors, we have osteoma, osteoid osteoma, osteoblastoma, and lastly, chondroma. Now coming for the malignant non-odontogenic tumors, we have osteosarcoma, chondrosarcoma, Langerhans cell histocytosis, multiple myeloma. Osteoma occurs in middle-aged individuals, mainly in the facial bone. It is associated with Gardner syndrome. It has features of obstruction of the ostium. Some patients will present with sinusitis. Osteoid osteoma seen in males under 25 years old. It is located in the cortex of long bones. It is characterized by nighttime bone pain that is relieved by non-steroidal anti-inflammatory. In the radiograph, a bony mass with a radiolucent mass will be seen. Osteoblastoma seen in males less than 25 years old, located in the vertebrae. It is characterized by nighttime bone pain that is not relieved by NSAIDs. In the radiograph, a bony mass with a radiolucent mass will be seen. Chondroma is usually located in the medulla of small bones, most commonly seen in hands and feet. Coming for malignant odontogenic bone tumors. First and foremost is osteosarcoma. It affects young teenage males, less commonly in elderly males. Osteosarcoma is a malignant bone disease that arises from osteoblasts, and it usually affects the metaphysis of long bones where there is high rate of cell division. The risk factors affecting osteosarcoma are mutations of the retinoblastoma, Paget's disease, Li-Fraumeni syndrome, radiation. The characteristic radiographical feature of osteosarcoma is sunburst appearance and lifting of the periosteum. Several subtypes are recognized histologically, but they are all categorized by direct formation of abnormal osteoid or bone by malignant osteoblasts. Here we have on the top osteoblastic, and down there is chondroblastic. For the treatment of osteosarcoma, radical resection is the choice of treatment along with pre- and post-operatively chemotherapy. Next is chondroma and chondrosarcoma. In which they arises from chondrocytes within the bones or sometimes within soft tissues. It affects predominantly the age group between 40 and 70, however, it may affect younger individuals. Most common sites of occurrence are the anterior part of the maxilla and posterior part of the mandible. As for chondroma, it's a benign tumor characterized by formation of mature cartilage. The presence of high degree of cellularity and plump and often binucleate cells are found. This raises a red flag that the tumor is a well-differentiated chondrosarcoma. Chondrosarcoma has 3 gradings, I, II, III, based on the appearance of the cells under a microscope. Microscopically we have Grade 1. Few mesenchymal binucleated chondrocytes, mitosis is rare. Grade 2. Increased cellularity, myxoid and less hyaline matrix, and lastly, Grade 3. Highly cellular, prominent spindle cell proliferation with prominent mitosis. On imaging studies, X-rays, CT scans, MRI, chondrosarcomas typically appear as areas of calcification or cartilage-like tissue within the bone. The primary treatment is surgical removal of the tumor. The prognosis for chondrosarcoma of the jaws is better for mandibular lesions compared to maxillary. Langerhans cell histiocytosis. It is a disease that is caused by clonal expansion of myeloid precursors that differentiate to CD1A+, CD207+. It is a challenging disease that may be presented in multiple ways, ranging from a solitary bone lesion that regresses spontaneously to a multisystem life-threatening disorder. Its incidence ranges from 2.6 to 8.9 cases per million in children that are less than 15 years, most commonly diagnosed at the age of 3. The most common site of bone involvement is the skull, followed by the spine, limbs and pelvis. Important feature for diagnosis of LCH. The neoplastic proliferation of CD1A, CD207, Langerhans, and S100. Under electron microscope, cytoplasmic rod-shaped inclusions are seen, which are also called Verbeck granules. LCH biopsy shows sheets of cells with convoluted vesicular nuclei admixed with eosinophils, as it is also called eosinophilic granuloma. Radiographically, in early stages it appears as lytic expansile irregular margin, cortical thickening and smooth periosteal reaction. It usually resolves, however. If it becomes chronic, it will appear as punched-out well-defined lesion with sclerotic margins. Multiple eosinophilic granulomas involving the jaws might result in loosening of teeth, giving the appearance of floating in air. For the treatment we have intralesional corticosteroids, if localized, and chemotherapy, if multiple organs are involved. Multiple myeloma is a type of bone marrow cancer. Bone marrow is the spongy tissue at the center of some bones that produces the body's blood cells. It's called multiple myeloma as the cancer often affects several areas of the body, such as the spine, skull, pelvis and ribs. Plasma cells are transformed into cancerous cells that grow out of control, crowding out the normal cells that help fight infection. These malignant plasma cells then produce an abnormal amount of antibody called M protein. Multiple myeloma, the exact cause has not yet been identified. It is heterogeneous, meaning that each case is unique. Though certain mutations have been identified as risk factors for myeloma, it is not a hereditary disease. The mutations that causes myeloma are more likely to develop spontaneously as people age. Occurs more often in males of Africa. The classic radiographic appearance is multiple small well-circumscribed lytic punched-out round lesions. The most common sites include the vertebrae, 66%, ribs, 45%, skull, 40%, pelvis, 30%, whereas involvement of the distal bones is unusual. Treatment is by chemotherapy and bone marrow transplant.